All right, thank you so much for allowing me to speak today. And also, I know I'm speaking about something that is upstream of what most of you do, but I think it's really important that you're all aware of what's happening in Canada and internationally, and also what's happening in the biomarker space in this field. So thank you for inviting me. I don't know, is there any other pulmonologist here? No, so I'm representing. So I have some disclosures there. So these are the three things that I'd like to briefly discuss. So kind of what's the state of lung cancer screening across Canada? What are the new novel technologies that are going to help us in our eligibility assessments? And I'll give you some statistics on what's happened locally in the last few years. So I probably don't need to tell most people in the room, but there was 2 large trials that came out that showed a benefit of lung cancer screening by low-dose CT over chest X-ray. And the trial, the NLST trial, is defined by me being a R4 in respirology. And the New England Journal of Medicine trial was defined for me by coming back from my fellowship and having started our screening program in 2018. And kind of being satisfied that, okay, I wasn't going down the wrong path in my career. So what is the sort of state of the situation in Canada? The first province to start screening Canada was Ontario in 2017. Quebec established its screening program in June 2021, and this was done really with a lot of help from the Canadian Partnership Against Cancer, who had funding to help with implementation, and each province had a funding envelope for implementation. And that was one of the reasons that Quebec was able to get off the ground, because of that initiative with CPAC. And it's really propelled the field forward. So right now, this is sort of the state, oops, how do I go back? The state of the situation right now. So in Quebec, we are at 12, soon to be, I think, 16 screening centers, and I'll kind of go through each province. In Ontario, 6, Alberta has 8, and British Columbia, even though they started after us, really just canvassed the province with screening. And I really applaud Stephen Lamb and Ronelle Myers, who really pushed that forward at a huge level. It's really impressive. So the Ontario screening program really started with a hub and spoke model. And the reason they started with this model, and that they didn't necessarily start with the university centers first, is because screening is a community-based intervention, and they wanted to demonstrate that they can do it in the community. And so they implemented screening in these regions that you see with the stars based on their population. And some of the centers like Ottawa that was involved in PanCan, a big Canadian lung cancer screening trial, was involved from the outset, but UHN was affiliated only later. So it was really a strategic decision from the ministry, and the decision there was to really use a risk-based model for screening, and I'll go into that after, that now all the provinces are using. Unlike in the US, it's very different. And so the Quebec program also aligns with that same principle of hub and spoke. So each university centers has a main screening site, and when we started, each one had one partner site in the community, not necessarily physically where we are. And we implemented the same principle of hub and spoke to ensure quality of care and appropriate referrals without increasing delays in the patient trajectory. And so it started as a demonstration project, and you can say you heard it here, but in January it will be an official provincial program, and it will be a permanent budget, which is great. And in British Columbia, they had a bit of a different approach. They looked to see where did they have the most lung cancer cases, and they decided where their screening programs were based on the distribution of lung cancer in the province. And so they just canvassed the province with screening sites. But they really did it from an epidemiologic perspective of where their cancer cases were. And Alberta, Alain Tremblay has been a really big advocate of screening in Alberta, and they have 3 sites with connecting sites as well. So they're just starting. This is the differences in all the provinces' screening programs. So The NLST trial used 55 to 74 years of age, but they had a quite broad pack year history, so 30 pack years and quit within 15 years. And based on that study, the number needed to screen was really, really high. And so this PLCO model that has different components in it, where you ask the patients about their family history, their smoking intensity, when did they quit? Did they quit 3 years ago, 10 years ago? Did they smoke 2 packs a day or 1 pack a day? All that thing is plugged into a logistic regression model. So it's still personalized medicine. You're asking each patient to do this questionnaire, and it's a huge challenge at a population level to implement that. And in the US, they did not go with the PLCO model because of the challenges of implementation. In Canada, the decision was to use the PLCO model because it's much more cost effective. And I'll show you that. Ontario and Quebec use the same cutoff of 2%, and that's based on a health economic assessment. That's why we use 2%, and BC 1.5. Interestingly, in Quebec and Ontario, the ministry decided not to include race because they didn't want people asking people's race on the phone. But unfortunately, that actually increases disparities in delivery because the race actually increases certain race increases your risk. So if you don't include that in the model, it's not ideal. And we advocated a lot for that, but there's only certain things that you could politically fight for at some point. And in Alberta, they're actually using a 3-race model that was more recently developed. All of the provinces, you can be referred by primary care, and you can also self-refer. In Alberta, it's the only place where you can't self-refer. So it's pretty amazing. You can call a 1-800 number now in Quebec, or I think it's 1-888, and you can get assessed for screening. And we really pushed for this because we didn't want referrals to be a barrier to enrollment. Each site has a little bit of a different navigation trajectory. I won't go over that in detail. And they all offer shared decision-making, except in Alberta, because they felt it wasn't, they didn't have the capacity to do that. And what I want to point out here, and I'm saying this because the industry is here and I have a lot of very involved researchers, is that we really push to have research aligned with screening in Quebec. And so thanks to huge efforts by Philippe Joubert, who's here, and my other colleagues in the province, we decided that patients who come in for screening would be offered research. They would consent to blood sampling. So while not everybody accepts to do the blood sample, we have now a huge group of patients who have consented to research. So it's not just the consenting to research to look at their data prospectively, but they've also consented to research for future studies. And if any of you are involved in biobanking, I think that that's a paradigm shift that's extremely important, because now that we have blood-based diagnostics and they're going to be more and more important as they come, consent for future recontacting is extremely important for patients. And so in Quebec, I have a CIHR funded trial that's looking at treatment of COPD in these patients, but the only reason we were able to get it off the ground is because we had embedded that consent in the program. Ontario and Alberta don't have integrated research, and British Columbia does as well. Sorry. So I just wanted to mention that actually Alberta reduced the age to 50, and that's because there is an increased risk in certain ethnicities of lung cancer at an earlier age. And they have the decision was kind of made that it just makes sense for it to be 50, especially for First Nations who get lung cancer earlier. And we're trying to advocate for that in Quebec as well. And as some of you may know already, in the US, the entry for age was changed by CMS and is 50, and it was really to reduce disparities in lung cancer delivery. So I won't go over this in much detail, but all the scans in our case are interpreted with lung rads, and I don't know if there's any radiologists in the room, but most of us had to give us our firstborn child to get them to use a template, but they do. And it makes a huge difference for a program to be able to use a template. So all of the programs are using the lung rads template. I want to highlight what they're doing in BC, which I think is amazing. And I wish that I could implement it in Quebec, but unfortunately, we're not there yet. We're trying. They're using radiomics to look at the lung nodule size, to look the solid to non-solid ratio. As many of you know, that's a really important marker for progression and outcomes. And they're also looking at coronary artery calcification and percent emphysema. And so they're using kind of a more fine-tuned nodule management protocol that Stephen Lamb and Renell have really worked on it a lot. And what's really nice for the physician is you get a report like this that really shows the risk, the doubling time. And so those are things that in future we're going to be able to use as part of our clinical decision-making tools. The software for volume doubling time is not yet integrated into the machines for CT, but probably in the next 5 years it will be. And so we won't have the same challenges we'll have with measuring this to predict outcomes. I think what's also important, and I say this because I'm a respirologist and I'm always thinking about competing risks, your percent emphysema, your coronary artery calcifications, also super important when you're looking at trial outcomes to realize that your population may have a lot of emphysema, they may have less. And so I think in the future, that's all going to be automated, because right now, I don't really know when my radiologist says mild, it's like 10 to 15%, and it's kind of a hocus pocus thing. But in the future, it's really going to be low bar, what percent emphysema, et cetera. So that's a very quick summary of what's happening in that space. And I wanted to talk to you a little bit about what is to come. And so this is the PLCO score that I was talking about that really showed that the number needed to screen to detect one lung cancer was 161 in those with the highest risk PLCO score. And that's based on, their race, education, age, smoking duration, BMI, family history, and history of COPD. So you can go from screening 5,000 patients and detecting one lung cancer with a clinical questionnaire-based tool to 161. And so this was why in Canada, most provinces have gone to this, and it's hard to implement, but it's much more cost effective, but it's very hard to beat this. So this is I remember the word in English, true Montrealer, and that I'm Fringlish. This is the barème, or the threshold that we have to really say, well, can you improve my blood-based diagnostics more than this? It's very difficult. And so how can we do that? Okay. So many of you in the room have probably heard of 23andMe, and you can get your polygenic risk score for cardiovascular disease online for about $1,000. So polygenic risk scores are really probably heard a lot about them in the press, but for lung cancer, they are relevant. And there have been multiple lung cancer susceptibility genes that have been identified, but each gene on its own is not enough to increase your risk. So it's the combination of the SNPs together that basically tells you what your risk is. So it's really that aggregate measure of those susceptibility loci. So if you have 6 susceptibility loci, you're at higher risk. So right now, from GWAS studies, 128 have been identified. And I'm an epidemiologist, so I am not a specialist in this at all. But what I can tell you is that this just allows me one more tool in my algorithm to tell me, is the patient high risk or not? So that sort of is happening already. And so should we use them to decide who should be screened for lung cancer? So what's the correlate? So the PLCO score selects for patients that tend to be older and have a higher smoking history. So I'm going to send them to you for treatment, and they're going to be sicker. So you want to really identify by screening less sick patients. So the advantage of the polygenic risk is that it assesses your baseline risk based on your whole genome sequencing, and it can delineate a population, and it's independent of those negative kind of prognostic factors like smoking and COPD, et cetera. So, I think it's something that is important. What the place is, we will continue to see. And I think we have a lot of work to do in the lung cancer screening community to identify competing risks and how we decide on our decision to initiate screening. One point here about non-smokers. So probably you guys have a lot of patients that want to be screened, or family members or kids, but be aware that these, you have to have a relative risk increase of 15 to have the same risk of someone who's smoking. So right now we have no tests in a non-smoker that increases your risk high enough. Even if you were asbestos exposed and you were exposed to secondhand smoke, if you're not a smoker right now, we're not there. I think it's going to change, but we're years away from that, unfortunately. So this is just to show you this kind of dose response relationship between the polygenic risk score and lung cancer risk, that as you increase your risk, and this is the initial validation study, but this is from the Onco Biobank, the UK Biobank, where this study was validated. And you can see as you increase your risk, when you're in a decile of 10% versus 90%, your odds ratio of developing lung cancer increases significant as your PRS increases for lung cancer. So what does that mean when I add it to my current screening program? So what happens once you add the PRS? So I decide I'm going to screen my patient, and I also do a PRS. So this is really looking at different groups, and I'm not sure if you could read the slide well, but on the top here, you have current smokers with about a 30-pack year history who are in the highest PRS for lung cancer over here. And then here you have kind of the 80th percentile. Here you have current smokers with a lower PRS over here. And so what you see, this is the age of onset of screening here, and this is your 6-year absolute risk of lung cancer on the y-axis. That, you know, we're using 2% as our cutoff right now. We should perhaps in these high-risk patients be advancing age of screening to 50 if they have a high genetics risk, because they have it's a sign that you're on one of these top curves and not on one of the bottom curves. And this is the never smoker curve. Okay, so that's where we are for never smokers. And I think one of the reasons is that the PRS, the lung cancer SNPs, a lot of them are associated with a nicotinic receptor. And so it kind of selects for a smoking behavior as well, we think. So what are other method of risk assessment? So there was recently, well, there's going to be published again in JCO in 2023, but they discussed at an American Thoracic Society meeting, this 4-marker protein panel, which has a precursor form of surfactant protein B. It has CA125, CEA, and CK19 fragments. And so they looked at how does that perform to predict lung cancer. So this is not in lung nodule patients. It's in patients with a normal scan who were in the PLCO trial. And they looked at the blood tests that they had before. So this is before diagnosis. So 0 is time of diagnosis. And I'll just show you here. So this is the AUC on this axis. And you will see that both in the late and the early stage patients, that there is detection of these levels with pretty decent AUCs, definitely 1 year before, but 2 years before diagnosis. So, you know, there's something in the blood that we are able to detect, and we can determine that there is a performance to that is not insignificant. So I think this is really interesting. And what they did is they looked at how does the blood test plus the PLCO clinical risk score perform? And you can see that the PLCO is just so good. It's 0.83 in their population. And they got it up when they added the blood tests to an AUC of 0.88, but that's for lung cancer mortality. Okay, this was for lung cancer diagnosis here, but here for lung cancer mortality. So I think this is really interesting, and it's coming, but again, the PLCO just performs so well to identify who's going to die of lung cancer. What else is coming down the pipeline? And I don't know how many of you here have worked with the NIH, but there's been huge investments in cell-free DNA fragmentomes. So it's not whole genome sequencing, it's looking at the fragmentation pattern in your blood. And lung cancer patients have high fragmentation, and patients without lung cancer have low fragmentation. They developed this this technology. It's called the Delphi technology. And it's not only for lung, it's for lung, colon, breast, but this is the data for lung. And I think that's a really interesting new data point, that sort of will eventually be used in risk assessment, but it's really, really new. And we actually might participate in a study looking at that, but it's really, really new. And then the other thing is, you know, patients always ask me after their first lung cancer screening, should I continue? You know, I had a normal study. Do I do another CT? You know, it's a big commitment. And so I think now we're learning that the patients with the lower risk scans, like the lung RADS 1 or 2, if they also have a low PLCO, there was a paper that came out in JAMA that you could potentially go to the next scan in 2 years instead of 1 year. But the patients who have a high PLCO score, you should continue annual screening because the risk is just so high. And I want to remind people that lung cancer screening, the benefit is not from your first scan, it's from your follow-up scan, because those growing tumors are what's going to kill you, not the ones that we detect on your first scan. Over. Okay, so I will skip this, but this is just about dysynapsis, that research that we're doing, looking at risk of cancer with your airway tree. So there's certain airway trees that put you at higher risk of cancer, and that's based on studies coming out of the data coming out of MESA. So that was, I just wanted to put that out there, that there's imaging-based biomarkers also. So I will quickly go to this. So just to let you know, this is where we're at in Quebec. We have evaluated 6,000 patients, and we've now screened, we have 3,000 patients who are screened, and about the same number who were enrolled in the program. And I want to thank everyone here in the room who has participated in getting screening off the ground.